Hello. Hi, I'm Dr. Magarelli from CNY Fertility. We're going to have another great evening of In Search of the Stork. My goal, of course, is first to teach something and then hopefully to come up with some questions and answers as it applies. But even if it doesn't apply, we'll do some question and answers after I do a talk. I think the key thing for me that I've been hearing a lot of questions about is the endometrium. So, hey, Jessica, good to see you. Hey, Mama Uterek Ku, jump over to Facebook Live rather than Instagram because I'm going to be doing a short lecture. Hey, my little Kason, or is that KJ Vaughn? Hello, KJ Vaughn. See if you can get your dad, that's my grandson, see if you can get your dad to jump over to the Facebook Live. Hi, Daniela. Good to see you on Facebook Live here. So if you folks are on Instagram, jump over to Facebook Live, YouTube, CNY Fertility Facebook Live, and we'll have a short little lecture, and then I'll answer all kinds of questions that you might have. I'm Dr. Magarelli, CNY Fertility, Colorado. Hi, Yesenia, Daniela, Jessica, you're on my super, I see you. Hi, Doctor, hi. So tonight we're going to be talking about the endometrium and the endometrial function. Have a little bit of a cold, so I may sound a little nasally, but I'm feeling just fine. But I just want, so if I sound a little nasally, that's what that's about. Doing great after my second COVID shot, so that was great. Hi, Mimi, good to see you. Diana, good to see you. Jesse Reddington, welcome aboard. Tiffany Tharp Calloway, hello. Tia Thorne Renuka, Stephanie King, hi Stephanie. Yes, my one of my acupuncturist here in Colorado Springs, Stephanie King, Dr. Stephanie King. She's at East Winds Acupuncture with my lovely wife, Dr. Diane Credenda. Hi, Samantha. Are you ever going to talk about tubal reversal, ligation reversal? Samantha, I'll give you the short answer. Depending on your age, the best you can expect with tubal reversal is about a 1 to 3% chance of success, depending on your age. So that will lead to a lot of questions, I'm sure. I hope the people on Instagram are jumping over to the darker side, to the Facebook side. Hey, Amber, can't wait for my cycle with you next month. Well, I can't wait to see you. Trey Cox, hello. I got a little heart already. Jolene, hello, Jolene White. Samantha, I did already talk about that. Can't wait for my cycle. Okay, Sabriana Lee Reed, what is your take on COVID vaccine while doing IVF? Absolutely, yes. I'm stalling for a few minutes here before I jump into my lecture. I think you guys can see my background, right? The In Search of the Stork, Fertile Soul. You guys can see that, right? I want to make sure you're seeing that and seeing me. And then I'm going to be answering questions at the end of my lecture or my discussion. I think it's a lecture because it's not really a discussion because I'm going to be telling you a bunch of facts about things. And then once we're done that, then we'll jump over and answer some questions. Oh, you can see me. Thank you so much. So let me move my cursor all the way to the other side here. Let me get a laser pointer here, and you'll be seeing my laser pointer here shortly. Okay, there I am. Okay. So we're going to be talking about what I call the fertile soil. This is your endometrial lining. And this relates to frozen embryo transfers, fresh embryo transfers, how much progesterone you need, how thick the endometrium is. These are questions I get all the time. Hey, Jennifer, thank you. That's my lovely master medical assistant team leader queen. And so the endometrium, I think of it as the soil where the embryo implants itself like a seed. So we're going to discuss what the lining is and why it's important. So if you look at this slide here, you see this beautiful image of the uterus. It's always looks like sort of an upside down pear. The lining here is called the endometrial lining, and this is what you shed every month. And again, you don't have to read a lot of this. This is more for my teaching slides, but the whole goal is for your body to create a nice thick lining here. And that lining is stimulated by estrogen, which I'll explain to you, and it's kept together by progesterone. So estrogen plus progesterone are really the way we maintain that lining. So the name of this talk was taken from Dr. Valbuna, and she just wrote a review in Fertility and Sterility on endometrial function, facts, urban legends, and an eye to the future. I kind of shortened it to just myths and the future. And so one of the things that she wanted to dispel was a belief is not fact. A belief is an observation. The observation doesn't necessarily mean that it's true. Every time my neighbor pulls out of his garage, I stub my toe. Well, that may be true, but it's not causal. Just because he's pulling out of the garage is not causing me to stub my toe, but some people can sometimes put that together. So, and then what happens is when there's an unknown, and this is what we get not only from doctors, but from patients, we start becoming illogical. We look for mythological reasons. Oh, I had to do it this way or that way, or my friend did it this way or that way. So we search for it, and then we apply these unproven tests and cures, and that's where bias comes in. And I'm trying to, with all my talks, I'm trying to get rid of this bias. So there's an anecdote is just an observation, is not data. So many anecdotes don't make data. And the actual quote is many anecdotes do make data because anecdotes allow us to ask the right questions. It doesn't give us an answer, but it asks us the right questions. And of course, Sir Francis Bacon said the best approach to understanding phenomenon is to verify, verify, verify. So this slide, I love this slide. It shows, this is a blastocyst here. And let me see if I'm going to actually get my head, maybe I'll get my head out of this picture here, but see if I can make it a little bigger. Just be patient with me for 1 minute because I want you guys to be able to see this clearly. So let me move this over here. I wish these slides were even bigger. Well, maybe you can read it. But here you see the blastocyst, and it is landing on these landing zones. They're ligands on the endometrial lining. This is the endometrium. This is the lining of your uterus. And these green little blotches here, there's like bars, 1, 2, 3, 4, 5, 6, are called penopods. And that's how the blastocyst recognizes the place to implant on the uterus. And it's a very specific areas. It's not the whole uterine lawn. And then once it connects, it begins to grow these tissues, these trophoblastics, and trophoblastic tissue is very invasive. So it invades the endometrium, gets absorbed and covered, and then this is where the fetus is going to develop. So in human implantation, our menstruation, is every month. The goal is to synchronize the arrival of the blastocyst into the uterine cavity so that the lining has to transfer and transform into a secretory, and I'm going to talk a lot about that, lining, to allow it to be juicy enough for this process to occur. And then it has to change into a placenta, right? It has to decidualize. It has to allow the invasion of if you see a blastocyst, those are called a trophoblastic tissue, and then you have the inner cell mass, and that allows it to invade, and then we create a placenta, and then we have a conversation between the mom and the baby. All of this is hormonal driven. So in the menstrual cycle, this is where you have your menses on the first, second, and third day of the menstrual cycle. You'll see that estrogen, as estrogen goes up based on the growth of the follicle, the lining, the lawn gets thicker and thicker and thicker. Once the estrogen reaches a certain amount in the body, there's a trigger that allows the ovulation to occur, and now this estrogen-producing factory over here becomes a progesterone-producing factory. So that allows this growth and sustaining of this lining nice and thick, which allows the embryo to implant, okay? That's what allows the embryo to implant. So it's all hormonally driven, and that's why we measure hormones, do things like that. So what's going on? So this is where menstruation occurs first, second, or third day, fourth day of your menstrual cycle. So this stage of growth of the lining is dependent on estrogen. So if you're doing an embryo transfer cycle, the first half of the cycle, you'll get estrogen alone. then you're going to see these new vessel formation. Well, now you have to stabilize these vessels nice and thick, and that's where the progesterone comes in. So this proliferates or grows during this section. And then in this section, it secretes this juicy stuff ready to allow the blastocyst to implant. Hello, Nellie. And then, of course, if you have implantation, it stays thick. If you don't, you lose it. And that's called your menstrual cycle. So here's another picture. If you look on the bottom, it's just showing you that image of the uterus where it's menstruating. Now you see during the growth or proliferative phase, during the growth of the follicle. These are important concepts because you guys hear this all the time. Your follicles are growing, your lining is getting thicker, but there's changes that have to occur. So the endometrium grows, gets thick and stabilizes thanks to the progesterone, and then it stays that way. And if you get pregnant, then you're definitely good to go. So why is this timing so interesting and critical? Well, after ovulation, fertilization normally occurs inside the fallopian tube. So the endometrium is growing, right? Ovulation has occurred here. It's beginning to make those changes. But it still takes 5, 6, or 7 days for that embryo to go through the stages of development. So we know about a day 3 transfer and a day 5 transfer. In reality, it's really not day 3. It's a cleavage stage embryo, a lot of different blastomeres, to a blastocyst embryo. So that has to be perfectly timed so that the lining is thick enough after ovulation, right? After ovulation, and stabilized enough to maintain the reception for the blastocyst. So here's just another picture. So transfer day, you drop the embryos in there, they're free floating. The implantation, you usually drop it right in the middle of the implantation window, which we're going to talk about. And then there's a conversation between the blastocyst itself, opposing, going next to, adhering, invading, and then you have a complete invasion. So when we talk about day 5, 6, or 7 transfer, we're trying to put that ready, because it's now ready for that process whereby it can implant. So it's ready to implant. And sometimes you actually see it hatching. So here's an example. This is the zona pellucida blastocyst. Here's a hatching blastocyst. So this blastocyst is really ready to adhere, adhese, invade, and begin the process of fetal development. Okay. So again, I on the bottom here, I wanted, because people wonder, well, how many days of progesterone? Why do we do so many days of progesterone? So here's that same ovulation, the transport of the fertilized egg, now embryo, divides into a 4 to 8 cell. So this is a day 3, 4 transfer. So you're going to have about 3 to 4 days of progesterone, because you start the progesterone the moment of ovulation in a natural cycle. So typically, because you're getting some from the ovulation, you can start your progesterone just a little bit after that day if you're doing it exogenously outside the body. But what if you're doing it day 5, 6, or 7? Well, you can see the window of implantation is right over here. So that's why we want to have a minimum of usually 6 days of progesterone when you're doing a frozen embryo transfer to allow implantation to occur. So all of this is simply matching your biology. When we give you medicines, there's no magic. It's just how closely can we replicate what nature has done. So here's a situation where there's 2 options, a smiley option and a sad option. In a smiley option, your estrogen allows the endometrium to get large, thick, get redder and redder, and then the progesterone stabilizes it. Now, if you get pregnant, then that progesterone continues, and you can see the fetus is implanting. I mean, the blastocyst is implanted and the fetus is growing. If you don't have a pregnancy, then of course these hormone levels drop, and the moment you drop progesterone, you have a bleed. So this is the cycle. This is this is all time. That's when I ask you guys to call on the first day of your menstrual cycle and basically make sure you contact us. It's because we're timing everything. So here's a picture of what's called the window of transformation. So here you have proliferation, and you'll notice these blood vessels are kind of close to the surface. Here the blood vessels are actually so close to the surface they're bleeding. But then here you notice that as the proliferation thickening, the distance between that blood vessel is is far, so that the person doesn't bleed. It's very stable, and you're seeing it's getting thicker and thicker with more and more secretions. And here you see the blastocyst on our window of implantation, approximately days 20 to 24, where the embryo can attach and grow. So this is what we're working on every time we're trying to time your progesterone and how important it is. And this is just showing you a blow up of that window of implantation. So in a normal menstrual cycle, if ovulation occurs here, implantation occurs 5, 6, 7, or 8 days later. Now, if you put an embryo on this endometrium, it's not going to work. You put an embryo on this side of the endometrium, it's not going to work. So this window of implantation is critical. So we're going to talk a little bit about endometrial receptivity in more detail, but I just wanted to show you why this term endometrial receptivity came out. And what it did was it went from a general understanding of when you should put the embryo in other words, should you put it in this window, to a personalized embryo transfer based on your body's creation of this days of implantation, receptivity. So this is pre-receptive, before the window, post-receptive. And people who've done the endometrial receptivity assay, they know these terminology. So what's going on when we say it decidualizes? In other words, once the cell, the endometrium starts growing, and we want to get changes in the lining. So here's the endometrium again. The blastocyst adheres, penetrates. But what happens is these thin stromal cells start getting thicker and thicker and thicker due to cyclic AMP and progesterone. So all of this juiciness that I kept saying, this allows these cells, these endometrial stromal cells, to have a landing spot, a very personalized landing spot, for the blastocyst. This decidualization process changes the endometrium. Women are amazing. Here's another view. This is a blow up of that same lining, and you can see these juicy little secretory cells lining the endometrium, very functional area. And you can see these stromal cells now with progesterone. You notice the progesterone goes up, these cells get thicker and thicker and thicker, and things like prolactin, insulin-like growth factors, various different types of proteins are produced that get the lining precisely ready. This is a wonderful picture, lovely picture of the implanting blastocyst and all the things that are happening. And I'm going to go through them just so you hear the terms. I mean, you're not going to think about this when you're doing your IVF cycle, but heck, if we keep studying these things, it becomes more important. Like angiogenic factors, what does that mean? So it means it produces new blood vessels. So the endometrium begins to secrete, because of the implanting blastocyst, these VGF, these growth factors for the capillaries, and so that in turn allows more blood vessels here. Now the invading placental type cells of the implanting blastocyst secrete HCG. Why? Because it is a mimic for LH, and LH forces the corpus luteum to keep producing progesterone. So now in an IVF cycle, of course, we give you progesterone, but in a natural cycle, the very pregnancy hormone itself is what is driving and keeping the progesterone levels high. These various growth factors within the endometrial lining, or within the body of the endometrium, are producing these growth factors, which allow, again, more blood flow, better tissue, better penetration. Proteins are produced. These capillaries begin to get bigger and bigger. These glands produce more and more, secrete more and more. And these are all the parts that have to happen in a beautiful synchronous way for the blastocyst to implant. So what happens after you create this relationship between the endometrium and the developing embryo, or now developing fetus, is that you're beginning to create these lakes of fluid between the mom and the baby. There's no direct communication. It's just free floating in these little lakes, which allow the transports, the creation of the placenta. Here you see a nice picture of the placenta, which then is the route by which nutrients come to the baby and waste products just go out to the mom. So this is all progeneration, making these new vessels, making these invasions, getting these different lacunae, or I call them little lakes. The lacuna means a lake, to grow with blood so that you can exchange gases, exchange nutrients. That allows the development of the fetus. There's your yolk sac. And when we measure your early pregnancy, we're measuring head to toe. This is the head, this is the toe, crown rump length. And you see there's a lot of blood vessels because it's feeding it. And then, of course, as the baby gets much bigger than the placenta, you know, you can see the disproportional change there. So these are all of the process. Okay, so in all stages of this, you need the right energetics, you need progesterone, you need the right balance. But here's the thing that bothers most humans. In humans, the efficiency of human implantation is around 50 or 60%. In rats, it's 95%, and in rabbits, it's 96%. That's why breeding like rabbits is a joke, is because their efficiency of this process is much higher than humans. So as I tell folks, 50 to 60% of all 20-year-olds pregnancies end in miscarriage and or cycles end in poor implantation, simply because it's basically the human phenomenon. So what happens if the endometrium doesn't work, or maybe it's timed wrong? So can it be dysfunctional? Well, if you displace that window of implantation, you put in the embryo at the wrong time, or you don't have adequate amount of progesterone, about 30% of women who have beautiful embryos will not get pregnant because their window of implantation is different than nature. And yes, Belair, I'm going to talk about on the day of transfer, what do you want to see the progesterone at? We'll be talking about that. So about 30% of women, we keep scratching our head and say, gosh, these are beautiful embryos. Why are you not getting pregnant? Why are you not getting pregnant? So what the Verbena did in her original study is a report which said, okay, now that we have all these beliefs about it, what do we know works or doesn't work? So endometrial scratching. How can does that matter? Well, I think the data is now pretty sure that it makes absolutely no difference in terms of pregnancy rates, whether you do scratching or not. Here you see 700 people who had the scratch, 700 people didn't have the scratch, and their live birth rates were exactly the same. And the problem with scratching is there's no study, it's not studied adequately. It's no standard treatment, no standard measure of good or bad effect, no benefit to implantation, none that they know of. Of course, costs money, causes pain, and potentially can cause scarring. As you can see here, you're scratching or tearing up the endometrium. So for the long time, they thought it was a good idea, but pretty much in 2019, that was laid to rest. Now, that doesn't mean we don't do it, but it just means that when you're talking to me and you ask me, well, do you think it works, Dr. Magarelli? I'll probably say the data does not support that it works. But what about all these other things, these cocktails of medications like aspirin, steroids, different types of ovarian stimulations, injecting HCG? Well, the studies, and these are 22 randomized controlled studies and a meta-analysis, said nope, doesn't necessarily help. The aspirin doesn't help, the prednisone doesn't help, the type of stim doesn't seem to matter. However, if you're doing HCG injections into the uterus before the retrieval, not the transfer, just before the retrieval, that could actually reduce a pregnancy in an IVF cycle. But again, nobody does that. But the bottom line is there's not a lot of data for these also. Now, in medicine, we do a lot of things that don't have a lot of data when we have a lot of ignorance, meaning we don't know the answers. So doesn't mean we don't use them. But what about things you can do? What about the site of how you give the progesterone? If you give it orally or vaginally or transdermally or in the butt, it doesn't matter as an injection. There's no difference. And again, 22 randomized controlled studies. So what they recommend is, why don't you consider doing vaginal plus something else? And that's what we do at CNY, is we combine vaginal with injectable just to sort of cover our bases. Now, I'm a big supporter of traditional Chinese medicine, and CNY certainly is a huge supporter of integrated reproductive medicine, yoga, their healing arts centers. And so there are a lot of other things that can increase progesterone. And, you know, if you want to, you work with trained fertility acupuncturists, and they can probably help you with some alternative medicine there. So, and also, it's not about blindly giving progesterone. There is a very specific time where progesterone must be given for this to work. And when we give you a protocol, those days matter, and the times of those days matter. So what the 5 randomized controlled studies said, the progesterone must start between the evening of the retrieval, when the egg was retrieved, which is the same thing as when the egg was ovulated, and 3 days post-retrieval. So progesterone has to start somewhere in here. We tend to start it a little bit earlier because we have we want to get it in on about day 6. Yes, it is critical that the timing of the progesterone is critical. Now, so getting to personalized medicine, the future, we went from this anatomic, let's look at the lining and see what it does, to this molecular molecules, this transgenomic profiling. And what we did was begin to look at 2 types of tests. One's called the Endometrial Receptivity Assay, and the other one is the Endometrial ER-Peak. Both of them, their goal was to see if we can create a picture in women when their perfect receptive timing is. So this is kind of how it's done. We do the biopsy, they extract the RNA, they do next generation sequencing, they give you a report, and then they correct. So if a person's report comes back receptive, it means leave it as it is. If it's pre-receptive, you need to start your medicine earlier. If it's post-receptive, it means you need to start your progesterone later. And then, of course, non-receptive is just ambiguous. So here's a picture of the window of receptivity, and it's just showing you why it's there. So here you see, 6, 7, or 8 days of progesterone. That window is pretty solid. And here you see if this person had 5 days, you see it's perfectly receptive, plus 5 days, which is actually 6. If they had it 7 here, it might be post-receptive. If they did it here 4 days, it might be pre-receptive. So our goal, of course, was to come up with the right protocol. Now, what about endometrial thickness? People who know when I do ultrasounds, I always say the day of progesterone, your uterine lining should look like Mick Jagger's lips. So here's Mick Jagger's lips. Here's the uterine lining, trilamina. This is exactly what you want it to look like, okay? So this is looking at 2,000 shared egg cycles where half the eggs went to a gestational carrier, half went to the mom. And what they found is that if the lining thickness was less than 7 millimeters, this measurement, they had a lower live birth rate, but anything over 7, they had a higher pregnancy rate and a higher live birth rate. Now, this is what the uterine lining looks like when we're looking at it. This is the trilamina or Mick Jagger's the lips kind of look here. But look at this. This is called hyperechoic. This is not good. In other words, if you find this on before you start the progesterone, it means there's something going on. But if you see this during the actual transfer, this is fantastic. Okay, so this is Gingold. He did a study looking at the endometrial thickness and pattern, and what he found was that age did not matter. In other words, the uterus doesn't age, therefore it doesn't matter how old you are, the responses are the same. Fresh versus frozen, again, implantation as long as you follow the pattern. The thickness did not matter. So a lot of people say, is my lining too thick? Well, they found anything from 5 to 15 or anything less than 8, it did not decrease the pregnancy rate. So this is helpful if your lining is 7 or 6. It just helps us. Ideally, it's around 8, 9, or 10, but I'll show you good data that says it really doesn't matter. And then the thickness on the day of transfer, again, didn't matter. Okay, so hyper-echogenic on the day of trigger, not good. All right, because this is when the eggs are coming out. But on the day of transfer, it's beautiful. So this means it's been affected by progesterone. So again, this study showed this is sort of an idealized. So some people talk about natural cycle versus conventional cycle, a natural embryo transfer stimulation versus a chemically modified or hormonal driven. And what this is saying is, as long as you understand the timing of where the embryo is going to be, so 6 days, here's a natural cycle, day 5, ovulates, and then this is a hormone replacement cycle where we prime you with estrogen and then start the progesterone. Again, it's showing you for blastocyst, day 6 is perfect. The HCG trigger can actually help you in a modified natural cycle. This is a natural cycle. This is spontaneous. So all we have to do as doctors is look at this and say, this is what you need. Okay, but what they found was there was absolutely no difference noted in live birth rates between any of these protocols if they're followed. So natural is not better than stimulated with estrogen and progesterone. Natural is not better than triggered or untriggered. Natural versus non-natural just simply is the same. So the endometrial stripe is the endometrium. Endometrial stripe is the endometrium. Okay. So here again, this is a study looking at if we customize using the ERA or the ER-peak. And by the way, those can be ordered. You could just say you want them. We typically at CNY will do them if we have a failed implantation. Certainly if we have a failed chromosomal normal embryo that just didn't implant when everything was perfect. You can order the ER-peak or the ERA even as a first line of testing. And what it does is it does a customizable embryo transfer. Now, I'm not suggesting that everybody needed it. Please don't read it that way. But in this study, they compared these patients who had repeated implantation failures. They kept not getting pregnant, put the embryo, not getting pregnant. When they were able to do the ERA or customizable embryo transfer, look at the pregnancy rates. These are the controls that they didn't do the customizable system, and these are the ones that got the ER-peak or the ERA. 75% of these folks got pregnant, only 10% of these other guys got pregnant, and you can see the delivery rates, birth rates, everything was extraordinarily high and extraordinarily significant. So customizing these profiles, not whether it's a natural cycle or not, that's not the way to customize. No difference. The way to customize is say, listen, I want to go the next step and do an ERA. Again, are progesterone support and levels important? Absolutely. If we don't give adequate amounts of progesterone and you don't have enough, the pregnancy rates are much lower than when you have adequate amounts of progesterone. And here you can see whether it's subcutaneous or, and serum, as they're looking at it, you can see that you need an adequate amount. In this study, it was greater than 10 nanograms per milliliter. Typically, we like it around 15 or 20. That's perfect in your blood. And then this is just showing in the world, when do people start the progesterone in an IVF cycle? This is hundreds of thousands of data points. 80% of all IVF centers started on the day of the egg collection and about 15% the next day, and very few do it any days later. So it's either on the day or the next day that you start your progesterone. And again, the effect of progesterone levels on pregnancy, absolutely. As the progesterone levels went up, they found it was not related to the quality, nor the fertilization, nor the cleavage rates. It was simply related to how much progesterone you had in your system. We don't have conclusive levels where it has to be a very specific number, but we definitely have levels which say you have to have adequate progesterone support. The thickness, this is a fabulous, and I think this is my last slide. This is a fabulous study, and it looked at thousands of patients, and it looked at the thickness from 3 millimeters to over 16 millimeters on live birth rates. Once you reached about 6, all the way up to about 16, no difference in live birth rates. No difference in live birth rates, whether it was natural, whether it was done with clomiphene, whether it was done with letrozole, whether it was done with gonadotropins. So the live birth rate relative to the thickness of the endometrium, really, once it's above 5 or 6, there's really no differences. So you can feel sure that if yours is 5 or 6 or 6 or 7, let's say, you can feel pretty confident. Anyway, that's a lot of information. I took a whole half hour. So my goal in that is to kind of introduce you to the fact that there's a lot of variability in managing our patients. There's no difference between a natural cycle versus a synthetic or estrogen plus progesterone. Okay, so I'm going to answer some questions. Do you do it with each transfer? No. Once you do an ERA, this is Oana Rowe, the ERA is good for life, we believe. Shelley Lewis, my estrogen is 234. My progesterone dropped from 21 to 19. That is absolutely means nothing. I take my HCG on Friday. Do not worry, Shelley. Those numbers mean absolutely nothing. Those are no difference. Miguel, we did an ERA and the results were 144 hours of progesterone. Transfer day 6, hatch 48, tested normal embryo, which failed. What can we do next? Well, Miguel, there's so much in that question. So it could be the embryo. Now, these are PGT tested, Miguel. I don't know how old your wife is, but too big a question. You do the ERA, the cycle before, or a couple of cycles before your actual transfer. How come some get a positive pregnancy test at 5 days post-transfer and some are not getting them at 8 days? I don't know what that means, Oksana. Danielle, great info, thank you. Thank you. I hope it wasn't too crazy. I have an no off-the-topic questions. I need to order my sperm, okay? Amanda, just keep trying. Kayla, 26-year-old failed frozen transfer, but embryo is beginning to hatch. Would I need more progesterone? No, not at all. Can focal adenomyosis be the cause of recurrent miscarriage? What treatment can be done for success? Diana, it's pretty hard to treat focal adenomyosis. Any kind of endometriosis can create an inflammation. So, the keto diet or immune protocols, acupuncture. Do you recommend HGH in a frozen embryo transfer cycle? Yes, for some folks, they just need an additional human growth hormone. I transfer tomorrow and COA has not checked my progesterone. No, they don't check your progesterone until you come in. When you come in, they're going to be drawing your bloods there. Kayla, 26-year-old failed frozen transfer, but embryo is beginning to hatch. No, we already went through that. People are getting, okay, we already went through that. Can FET be done and successful without taking estrogen? Not likely, my dear, unless you're doing a natural cycle, but boy, I would not do that. It messes up timing. Miguel, your wife is 40 years old. HSG came back normal, no fibers. No, can we assume age is a factor? It's always a factor, Miguel, especially over the age of 24. Age becomes a big factor, especially over 35 too. Is it possible to overdose on progesterone when giving shots and vaginal? Not really. They have not had there's no high number for progesterone. There's only a low number for progesterone. Is there anything that can be done to encourage implantation outside of progesterone and estrogen? Absolutely. Acupuncture, traditional Chinese medicine, the keto approach, fasting, avoiding alcohol, tobacco, drugs, serovital, growth hormone, some of the immune protocol adjuncts that we can add on. Johanna, I'm cycling day 16, lining is 5.3, taking aspirin. Now adding I lost that. Now adding Viagra. Is it worth it? Okay, that's just too much information. After transfer, what do you look for in midway labs? Estrogen and progesterone. It is not Oana. If not, the entire endometrium is receptive. How do we know where to drop the embryo? Great question, because the embryo itself floats around for up to 48 hours and it looks for and attaches to, it doesn't really look for, but attaches. That's a great question. So when you put that embryo in there, you're not putting it in the place. The body will find it. Christina, thank you so much. Oh, God, you're so welcome, Christina C. Sherry, what is the best steps a 40-year-old with one failed IVF do? A second one. What are the chances of an ectopic with embryo glue? Does embryo glue prevent ectopics? Absolutely does not prevent it, and it doesn't increase it as far as I know. Woo! Is it normal for uterine lining to go from 8 millimeters 2 days before ovulation to 6 millimeters? Remember, a millimeter is extraordinarily small and on an ultrasound, very When do you take Serovital? Serovital is something you start after your first visit with CNY. Just start taking it. You can get it at Costco. You can get it online. My lining on day 9 was 20 and trilamina. Is that okay? Sure. When is your transfer? Thoughts on HCG wash? Absolutely. The reason I showed you that really cool image of the uterine lining is that HCG plays a big role in preparing that endometrium, or in keeping that endometrium holding on to the baby. So I'm liking it better. Do you recommend bed rest after a transfer? I actually do, Shelby. That day and the next day, it's been a long journey. Give yourselves a break. What if I produce my own progesterone naturally? Can I take less progesterone shots but still take it vaginally? Well, Portia, you can do anything you want. But the bottom line is the more you change stuff, the more you make it harder for us to figure out what's broken. Nurse at CON told me to start estrogen and progesterone only a day before fresh day 3 transfer. Was that too late? No, because it's a fresh day 3 transfer. Remember, it's the day of retrieval up to 3 days later, you can start. Now, Claudine, the estrogen, on a fresh transfer, remember, we're not talking about adding estrogen. We only talk about adding progesterone typically. But we add estrogen after a fresh transfer because we found that it helps a little bit, but its key is the progesterone. And so you're starting your progesterone. You're getting it from the follicles that we penetrated to get the egg out. They become corpus luteum, and then that produces a progesterone, and also you can give it exogenously. How do you feel about PGT? Oh, that's a different topic. I'm pretty sure my transfer failed. Don't be sure of that. I'm sorry. Can I do HCG boosters? Of course. If you folks download our family building guide from cnyfertility.com patient resources page, read it, man. There's so many different things we can do. You said that Serovital and something else. Didn't catch what you said. This is Erica. Is it another similar thing? Well, Serovital, human growth hormone, acupuncture, traditional Chinese medicine. Does it matter what day to transfer in a frozen embryo cycle? No, it's exactly hours, not days, when you've done an ERA. I don't know what MNM is, Erica. And Megan, adenomyosis is endometriosis in the muscle wall. I'm not 100% sure it has a lot to do with implantation failures. I think that's a stretch. What do you recommend for recurrent implantation failures, Hashimoto's and PGTA? Do IVF with genetic testing, get as many eggs and embryos as possible. The number one proven treatment for recurrent pregnancy loss that's not explained is genetic testing of the embryos. So that's something that you can do. Of course, Miguel, my pleasure. Okay, how are we doing out there, folks? I don't think anybody's on Instagram because I told them not to be, but let's see. There we go. I guess I lost the connection because I didn't do anything. All righty. Okay, Portia. Okay, you're welcome. All righty. I'm 41, did not get pregnant through IVF, but had a DNC in December. My recent test numbers are AMH of 0.32 and FSH of 15. Is it time to look, Natalie? Kind of, yeah. It depends. I mean, you've tried the IVF. You're 41, very low ovarian reserve. Yeah, I would. MNM is nicotinamide mononucleotide and NAD. Precursor. Great question. You're wondering if I don't know anything about it. Sorry. Does having a small uterus affect the lining thickness? Is it thinner in general? Not necessarily, Stacy. Oana Rowe, is PRP injected into the ovaries improving the endometrial line? Improving endometrial lining? No. AMH for a 39-year-old should be 1.5 to 2. Shelly, you're doing great. You're doing great. Sleep well tonight. And awesome researcher. Awesome research, Erica. So I'll have to look that up. NAD. Oh yeah, NAD plus. Yeah, I know what that is. Now I don't know its mechanism, but yes, I've heard about that. Can we have one phone? And if so, what's the cost? One phone. Don't know what that is, Sherry. Does the place where embryos implant move around the uterus, or is it roughly the same place each time? No, Jessica. There are many places within the uterus that the embryo can implant based on its response to its hormones. I think it's of it like an ocean with a lot of different tributaries and bays, and the ship goes around and finds a pretty bay. PRP and HCG was together in Is That Good? Wash, I'm assuming. You know, there's no studies, Belair, but it's certainly something you can try. Is an AMH of 1.6 low for a 33-year-old? Not necessary, Alyssa. It's age that matters, really. And how long before stims to start DHEA? Go to our website, cnyfertility.com, patient resource page, and all of the dosages are there. When we put Elaine, great question about where do we put the embryo? We put the embryo at about a centimeter to a 2.5 centimeters from the top of the uterus. We don't put it at the top. We don't put it at the bottom, sort of mid-fundal, but you don't want to touch the top. You want to kind of get it about a centimeter from the top. FET is only performed at a certain time in the month. I just finished a cycle and was told I have to wait for my next cycle. Okay, I'm not sure. I don't know what that means, Jane. Can we have one phone call? And if so, what is the call? Oh, Sherry, got it. Oh my God, of course. All of our consults are either by Zoom. And please, if you guys want to do Zoom meetings, I really like Zoom meetings because I like to get to meet you. You don't have to just do phone. We could do Zoom. And then all you do is call our 800 number. And yeah. So is hatching embryo have more chance of sticking than unhatching? Yes. There's a lot of work to break through the zona, and some of us now are doing what we call taking off a cap, decapitating with the laser, just to make it easier for the embryo to come out, the blastocyst to hatch. What is the size of a mature follicle that would prompt retrieval? Somewhere between 18, some people say 17. I tend to look at 8. In Colorado, we tend to think 18. So 17 to about 22 mean diameter, the diameter across. Great question. Is IVF needed with an AMH as an Reiki? IVF is used for many, many reasons. You could do it at age 20, you could do it at age 44, but there's sperm issues, tube issues, uterus issue, failed IUI issues. So you don't have to have a reason to do it other than yeah, I was told that you guys don't do video consults. Well, they asked us to sort of stop for a month, but I'm going to sort of talk to them again. I love them. So, you know, if you're talking to me, you can ask for one and I'll be happy to do it. How about whether it's going to be right, left, or middle of the uterus? No, there's no right, left, or middle. It's the uterus, when you put it in, it's filled with a beautiful mucus. It's an ocean. The embryo floats on that ocean until it finds a port it likes. Does embryo hatch before it's frozen when it's getting unthawed? No. Does embryo hatch before it's frozen? No. You try not to hatch before it's frozen. Is day 3 transfer better than a day 5? Trey Cox. Well, if you're less than 35, I'm kind of a day 5 guy because that's going to tell you more specifically which embryos work, because most untested embryos is nothing more than a beauty contest, and it's a longevity contest. Those embryos that last the longest in culture have the best chance of implanting. Your chances double from day 3 to day 5, relatively speaking. Your chance of pregnancy doubles, okay? Yeah, so there you go. So I would do day 5. Does CNY use the magnetic nanobead sperm selection process? Don't even know what that is. I have no idea, hopeful. Magnetic nanobead sperm selection process. It must be something on the internet. Not familiar with it. Magnetic nanobead. I'll look at that up, but I don't know what that is. Magnetic nanobead sperm selection process. Very low AMH is low stimulation. Yeah, a mini protocol. Yes, Alana. Missy, I'm 47 doing donor egg. Is there anything I should do to better positive transfer? Oh my God, yes. Missy, acupuncture, keto, avoiding alcohol, tobacco, drugs, all the wonderful vitamins on our CNY fertility website, all that stuff, yes. And then we have different protocols. Yep, at my job, we only transfer day 5. I'm an IVF nurse. I'm nowhere. Nope, we do transfers on day 2, 3, 4, 5, 6, 7, 8, or 7, not 8. Amy, round 3 starts tomorrow. I'm 41. Embryos were frozen day 3. Would we get a better idea if they would be successful at day? Can we thaw and let them grow, or is it too late? They're day 3. You certainly can, but you only want to thaw the number of embryos that you want. So if you thaw 2, you can wait and see if they grow, but I still think the uterus is the best place for them, not a lab. Do you recommend going straight to another egg retrieval right after a failed transfer, or is it okay to wait 2 months and do supplements, Miguel, since we didn't do it the first time? Yes, get yourself a healthy body, do the acupuncture. Go to the American Board of Oriental Reproductive Medicine, ABORM.org. Go to Healing Arts Center at CNY Fertility, or go to eastwindsacupuncture.com, do a telehealth. Yeah, there are lots of things you can do with healthy body, fertile body. Do I need special meds for MTHFR hetero? I said it's not related to recurrent pregnancy loss. Yeah, there's a debate between geneticists. I just say make sure you're getting at least 1 milligram or 1,000 micrograms of methylated folic acid. Methylated folic acid. With regards to how long does the PRP effect last, we don't know the answer to that. Oksana, I'm 30. Should I stick with transferring only 1 embryo, or should I try 2? If you failed, Oksana, with 1 untested, definitely try for 2. Erica, this is the NMI video. It makes mice fertile. Okay, well, okay, that's good. Have you ever done university lecturing? Your voice and lecturing method is perfect for it. Oh my God, Elaine, I've been teaching. I teach at Yosan University for acupuncturists, 5 branches. UCLA, I've taught at. Was a professor at Michigan State University. I was a professor at the University of New Mexico. I teach around the world. I love teaching. And I love for you guys to get power by learning the knowledge about the science, which I love. Melissa, at the start of menses, what if your progesterone is above 1 and takes a few days to get below 1? That has nothing to do with your receptivity. Nothing to do. All righty, we are at 5:25. Oh, Amber, my dear daughter. I love you. That's Amber. She's my daughter. Thank you. Oh, you like my PowerPoint. Doc Tia. Ooh, she must be a doctor. Hopeful. If you have a 4cc and a 5cb, both PGT normal, which would you suggest we try to transfer first? 29 PCOS. 4cc and well, I would go with the 4cc. I mean, yeah, why not? But either one, they're viable, and if they're chromosomally normal, the grade does not matter. Okay, Blair, thank you. I just had a failed cycle at another clinic. I have stage 4 endo, diminished ovarian reserve, 0.2. We transferred our only 2 day 3 embryos and neither stuck. Sorry. I just said I should try donor eggs. We decided to schedule a consult at CNY for a different second opinion. I'm 33 and we've been trying to conceive for 10 years. What can you recommend to us before our consult in May at CNY? Is there something we can do to better our chances? Absolutely. We provide free of charge. Go to CNY Fertility Patient Resources. Download the Family Building Guide. Immediately, wherever you live, find out, go to www.aborm.org and find an acupuncturist who's been trained next to you. If not, go to eastwindsacupuncture.com and talk to Dr. Credenda, my lovely wife, and she'll help you find one. Number 3, purchase Zero Vital, Serovital, from Costco or online, and start taking it. It's a growth hormone secretagogue. It provides more and more growth hormones, so it's how things work. Number 4, make sure you have copies of all of your records, so you send them ahead of time. So it makes it really good for us to know about you on the very first visit. Number 5, avoid alcohol, tobacco, street drugs, both of you, male, female, if it's a husband, sperm A kind of thing. All of these things, healthy body, fertile body. Kinda, do you think it's absolutely necessary to do genetic testings of the embryos before transfer? Absolutely not. I do not believe it's absolutely necessary. Does CNY facilitate shared donor egg cycles? My presumption is absolutely. Oh, there's that lovely Jessica. She's like, I need to hire Jessica. You're just so helpful. I appreciate it, Jessica. That's where you get the information. Family Building Guide, FBG 2019 version 3 compressed PDF. Yes, absolutely wonderful. Where are we at? Okay, a couple of minutes. So more than likely, next week will be more questions and answers rather than a topic. I try to intersperse it because a lot of people have a lot of questions. La Medina on Instagram, hi. If you can, go to CNY Fertility Facebook page. It's a much better way for us to teach. But if you have any questions, unfortunately, I'm sort of running out of time, but if you have any questions, just pop them up there. So next week, it's going to be mostly questions and answers. Happy to say Dr. Banerjee has been working with me here, so I'm really excited. And Dr. Skosnik and Dr. Fink and my nurse practitioner, Amy. We have broken the magic 100 cycles a month, so we're getting into the realm of a big program, so that's being helpful. We've now opened up another 6,000 square feet at our facility for our patients, so it's absolutely wonderful. We have a whole floor for the clinic, a whole floor for the lab. Everything is going S, not C, SEROVITAL, Zero Vital, SEROVITAL.com. Okay, thank you for appointment coming one day. First consult coming up, Erica. Send all your stuff in. What % of your thoughts process drives the example? Thinking positive. Oh my God, Belair. When I say a healthy body, I mean a healthy mind, a healthy spirit. Love each other. This is key. The reason you're bringing a child into this world is two people love each other so much that they have so much extra love. They pour it into this next being. So absolutely walking hand in hand with your partner 30 minutes a day, having peaceful thoughts. Get the vaccine, everybody. Please get the vaccine. Please get the vaccine. Well, Amy, thank you, everybody. Thank you, Wendy. Thank you, Angie. Thank you, Jessica. Thank you, my Jennifer. Thank you, my dear daughter, Amber. Thank you, Kason, my grandson. Thanks for, thank you for sharing another wonderful evening with me. Yes, I do enjoy these. Yes, it really oh, by the way, the Serovital, just because don't get the high-end one, get the basic one. The high-end one has caffeine, just get the basic, the less expensive one. Hopeful, I'm hopeful for all of you. I wish you the best, and be safe out there. Love each other, and I look forward to seeing you. Send me some kisses. Everybody, come on, kisses. Here, I gotta see a couple of kisses before I go. Some hearts, kisses, hearts, anything. All right, everybody. We'll see you later. Thank you. Bye, everybody. Let's see. Pointer. Get rid of that. And then come here. All righty. Thanks, everybody. Bye.